Dr. Pankaj,
Thank
please.
you, and morning, everybody. Thanks the organizer for giving this opportunity to talk about the stem cell experience. So, my talk is easy because the previous speakers have already given you the basis of use of stem cells. Uh, Both Dr. Dharma's and Dr. Keating's talk. So the first I would uh, uh, just let you know about the bed strength in PGI Chandigarh. It is around 1948. The annual indoor admissions is almost 100,000 or 1 lakh. The annual outdoor patients we see approximately 27 lakhs in a year. Whereas if you look at the population of Chandigarh city is only 12 lakhs. So more than the population, the number of patients actually come to our hospital. The adult hematological disorders, we see approximately 46,000 in a year. Just to, for people who are not very familiar, I would just show them where we are. So we are based in the northern India, in the foothills of Shivalik Mountains, and this is Delhi. So it is around 200 miles northwest of Delhi. The hematology services in PGI Chandigarh, the lab hematology separated from the main histopathology in 1976. The adult clinical hematology services was started in 1978, and the pediatric hematology services was started in 1982. We also have the fellowships program, which is running since 2009, the DM pediatric hematology oncology, the adult DM clinical hematology, and hematopathology. The transplant program was initiated in the year 2003. We have a 10-bedded separate bone marrow transplant center which was made functional in 2005. The first auto transplant was done in October 2003, and the first allogenic was carried out in 2007. Currently, we are performing 4 to 5 transplants a month with a ratio of 3:2 auto and allo. This is the number of transplants. So we had only one faculty in 2003 and we started with the auto transplant. And in 2007, we did the first allo transplant. And by 2011, we were doing approximately 15 transplants a year. But here we had an additional faculty in 2011. And then the number of transplants actually gone up. And currently we are, as I said before, doing around 50 transplants a year. We have done approximately 285 transplants from October 2003 till 18, and I would be sharing some of the data. The indications of autologous is majority multiple myeloma or plasma cell dyscrasias, lymphomas, Poem syndrome, and Kesselman disorders. The allogenic transplants are done in acute myeloid leukemia, aplastic anemia, ALL, CML, and these are some of the malignant as well as benign hematological disorders. The indications have already been told by Dr. Dharma Chaudhary in the previous talk. So the sources of stem cells, mainly we take the hematopoietic stem cell by mobilizing from the blood, almost in 97% of patients, whereas in the pediatric patients we are still harvesting from the marrow. The median age of these patients is 27 years, and the minimum age of the patient which was transplanted was 3.5 months. The maximum age is 65 years. Majority are male patients, and you can see the majority of the patients actually, because it's an adult hematological clinic and transplant center, so majority of the patients are adult patients. We have, as I said before, the auto transplant and allo transplants. This is the ratio, and this is the donor type. The match sibling donor, match unrelated donor, match related donors, and this is interesting that sometimes we believe that it is only the siblings, but sometimes even the parents are actually a match with the child. So these are match related donor, and haploidentical are only few. Graft versus host disease has been told by the previous speaker. This is useful also for at least in malignant hematological disorders. So we see approximately 40% of patients had acute GVHD and around 30% of patients have chronic GVHD. And these are the different sites where we can have the effect of graft versus host disease. The mortality is is approximately 6% in day 30, and day 100 mortality is approximately 12%. And this is at par with whatever the international norms are. I would share some of our data which is published in the literature, and this is about the autologous stem cell transplant for myeloma. And this is data of 94 patients. The median age was 53 years, and majority of the patient actually present in an advanced disease. And you can see the staging system which is done in myeloma. The third stage is seen in more than 50% of patients. In myeloma, we have a heavy chain and a light chain involvement. The IgG kappa was highest, then IgG lambda, and light chains were approximately 16%. The interval from diagnosis of myeloma to transplant varies, and varies from 9 months, actually, this is not days. And the chemotherapy cycles, most of the patient received 6. So we have done transplant who have received 2 cycles up to 19 cycles. The regimens which are used for treatment of myeloma are Cybode regimen or a VCD regimen. These are chemotherapy regimens mainly consisting of immunomodulatory drugs with steroids. The VTT, VRD and miscellaneous regimens. The response rates are approximately almost half of the patients actually achieve complete remission. VGPR is seen in 39% patient, PR is 5%, and whereas in spite of giving chemotherapy, some patients do have progressive disease, which is 14%. The harvesting of the stem cells is generally done with granulocyte colony stimulating factor, which is given for 4 days. And there is another agent which is used for harvesting, that is Plerexa 4. Single harvest is done in around 51% of patients. The median CD34 count or hematopoietic stem cells count is 5.1 million. Neutrophil engraftment took place in 11 days, platelet engraftment took place in 12 days, and platelets more than 50,000 is achieved in 19 days. Mucositis, which is because of the high dose chemotherapy, is seen in 38% of patients. Vomiting and diarrhea are quite common in these patients who receive high dose chemotherapy. Febrile neutropenia, which means when the neutrophil counts are almost less than 100 and the patient develops fever, is seen in 3/4 of the patient, and the use of empiric antifungal was seen in 58% of patients. The 30 days transplant related mortality is approximately 3%, which is well within the what is seen at other centers. The hospital stay is approximately 29 days. In the West, most of these autologous transplants are done on outpatient basis, but in India, because of the infection rate, generally we admit these patients. The cost, since being a government hospital, the cost is, average cost is 200,000, varies from 50,000 rupees to 600,000 rupees. The overall survival of these myeloma patients was 77% at a median follow-up of 6.5 years. One of the paper which is published, we have looked at the cost effectiveness of doing a transplant versus continuing the chemotherapy based on the Markov model. And you can see here the cost of transplant and other things were almost equivalent what you see with the conventional chemotherapy. I would share a few more publications from our transplant center. One is the HLA match likelihoods for Indian patients seeking unrelated donor transplantation graft. This was a multicentric kind of a study, and HLA data from 14 centers were collected. This was published in Lancet Hematology, and so we tried to find out what is the probability of finding a match donor from the registries. And so what we could arrive at that if the registry size is 25,000, there is a chance of 14% of getting a match. Whereas if the registry size is 100,000, then it goes up to 60%. So meaning thereby as the number of unrelated donors, their number increases, the match also increases. When we harvest the stem cells, we are storing at 4 degree rather than cryopreserving those stem cells. So this actually cuts down the cost. This was a paper which was published in 2005. Again, looking at that if we are storing at 4 degree, this is all these patients actually engrafted and there were no complications. One of our earlier patients actually had pulmonary veno-occlusive disease, which is a quite an uncommon kind of complication which is seen in autologous transplantation. Some of those case reports, Dr. Dharma has shown you GVHD. So this is a patient who are applying betadine. So we were thinking that this is a betadine rash, but actually, and over a period of time, he developed some of these lesions. And when the biopsy, it was showing graft versus host disease, and he was treated for the same, and he improved. When we are giving high dose chemotherapy like melphalan in multiple myeloma patient, some of these patients do develop ventricular arrhythmias, and this is one patient who was monitored and developed arrhythmias, and it subsided on its own after in next 24 hours, meaning thereby as the melphalan excretion goes up, the arrhythmia settled. For some of them who belongs to pathology, so this is oval jolly bodies like inclusion in neutrophils and monocyte of a transplant patient who actually had a viral infection. And then a patient who developed hemorrhagic cystitis, which was actually related to adenovirus, and you can see some of these lesions on the glans penis, on the skin, and on the palmar aspect of the hand. So finally, coming to the conclusions, the hematopoietic stem cell transplantation is an important advancement to treat benign and malignant hematological and congenital disorders. The autologous transplant has low mortality and leads to prolongation of survival, whereas allogenic transplant has high mortality as compared to autologous, but is curable in majority of patients. And hematopoietic stem cell transplant is truly a team effort. With that, I thank you very much for your kind attention.
Thank you, Dr. Pankaj Malhotra.
Disease also there?
So most of the time when you are doing autologous transplant, you want the disease load to come down as much as possible. The autologous basically is you are giving a heavy dose chemotherapy and then rescuing the bone marrow with stem cells. Whereas in allogenic transplant, you are using the immunological effect of the graft. So in both the situation, you want the disease load to be as low as possible. Only then some of these things are successful.
Which conclusions have you drawn from the study into the different regions of India? Are you exchanging this data throughout the huge country and the huge population? And are you going then preferably for cord blood, which is more compatible?
So we have an Indian stem cell transplant registry, and we generally have, we have approximately 76 bone marrow transplant centers in India. And the majority of the centers have come up in the last few years, actually, as the number of people who got trained in transplant have gone up. So they have gone to different places and started their transplant centers. In India, we, as has been said before, the umbilical cord is mostly private banking rather than a public. We do not have a public cord blood bank in India. And with the current in the last few years, the haplotransplant is coming up in a big way. So majority of the time we are doing sibling matched donor, we are going to the matched unrelated donor, and currently we are going for the haplodonors rather than for umbilical cord stem cell transplants.
So Thank you very much, Dr. Pankaj Malhotra.
Thank you.